Well, we have a handful of people still trickling in, but if it's okay with everyone, I'll sort of kick off the session with just a brief introduction, and then I'll hand it over to our session moderators, Peter Lee and Tessa Crilly, both from Ohio State. So tonight is the first installment of this year's CAPER Pancreas Academy webinar series. And this is an annual event that CAPER puts on with the goal of sharing some information about pancreas management. Our focus is to sort of make it Pancreas 101 and 201 so that it can be, I think, digestible and educational for people who may be new to the pancreatitis space. Tonight we have two very accomplished speakers who will be talking about the hospital management of acute pancreatitis. I am hoping that we will learn quite a bit about hospital management, and at the end, Peter and Tessa can talk to us a little bit about their experiences and sort of guide the Q&A at the end. So without further ado, thanks everyone for joining. I'll turn it over to Peter and Tessa to MC the evening.
Thank you everyone for coming. So just gonna introduce Dr. Papacristo here at the colleague of mine and also my chief at Ohio State Wexner Medical Center. He's the professor of medicine at gastroenterology, and he specializes in pancreatical biliary diseases and practices state-of-the-art ERCP EUS, and also a very accomplished researcher with multiple NIH funding in the area of acute pancreatitis. And he's gonna talk to us about a very practical topic, fluids, antibiotics, and endoscopy in acute pancreatitis. So George?
Great, thank you, Peter. Thank you to Mitch and Steve for the invitation. And of course, CAPER Academy. I'm looking forward to the discussion with Tessa and Peter and all of you at the end. I'm going to be focusing on fluids, antibiotics, and endoscopy. The management of acute pancreatitis includes early fluid resuscitation, use of antibiotics, nutritional support. There is a role for ERCP in certain cases, but also we want to correct the primary insult and prevent future attacks with cholecystectomy in biliary pancreatitis, cease of alcohol use or abuse in alcoholic pancreatitis, and correct triglyceride and calcium levels as well. Again, this is an overall management slide, but we're really going to focus on early fluid resuscitation, antibiotics, and ERCP. Fluids is the cornerstone of therapy in the first 24 to 48 hours. Unfortunately, we do not have any pancreatitis-specific treatments. So fluids are critical. Where do we stand in 2024 as far as fluid resuscitation? I'm going to start first by presenting a recent trial, multi-center trial on different rates. This was a randomized controlled trial, the waterfall trial that enrolled 249 patients, which were randomized to what we call moderate versus aggressive fluid resuscitation. The study was multi-center, very well received, published at the New England Journal of Medicine now 2 years ago. And this study showed that actually aggressive fluid resuscitation does not prevent moderately severe or severe disease when compared to moderate fluid resuscitation, but if something, it results in significant fluid overload. So again, there is no significant improvement in important clinical outcomes with aggressive fluid resuscitation, and there is definitely concerns from fluid overload, as it is shown in this randomized controlled trial. So where do we stand in 2024? We are following moderate hydration with a goal-directed therapy. Our goal is potentially to give a liter of bolus upfront, especially in those patients that appear to be hypovolemic, followed by 120 to 150 cc's an hour for the first 48 hours. This translates to around 1.5 ml per kilogram per hour. how do we assess? This is a dynamic process. How do we assess if we adequately hydrate patients? We do that in the first 6 hours, but also at 24 and 48 hours. We're following their vitals. We're looking for tachycardia, hypotension. We're following the urine output and want to see improvement in the urine output and correction of hemoconcentration if it was present on admission with drop in the hematocrit and BUN levels. Persistent BUN of more than 25 or a raise in BUN is definitely concerning. We talked about the rate. How about the type? The two main fluids that we're focusing on are both crystalloids, is the lactated ringers and the normal saline. In a prospective observational study that we completed a few years ago with more than 1,500 patients that were enrolled in 22 international centers, what we call the Apprentice Consortium, we found that LR during the first 24 hours is associated with reduced odds of moderately severe or severe acute pancreatitis with an adjusted odds ratio of 0.5 compared to normal saline. And that was confirmed after we adjusted for region, etiology, BMI, and fluid volume. Again, up to now, we have this observational prospective study in small randomized controlled trials, but the follow-up of the waterfall study is the Waterland trial. Again, a multi-center randomized controlled trial, international. The goal of enrollment was 800, and the enrollment was just completed approximately 2 weeks ago in 41 centers. So we're looking forward to the Waterland trial results. Moving from fluids to endoscopy, what is the role of urgent ERCP? This paper was published 4 years ago at the Lancet. Again, another landmark study from the Dutch Pancreatitis Study Group that really studied the need or the role of urgent ERCP with sphincterotomy versus conservative treatment in predicted severe acute gallstone pancreatitis. They were able to randomize 230 patients with predicted severe acute pancreatitis, and predicted severe was defined as an Apache 2 score of 8 or higher, or an IMBRI score of 3 or higher, or a CRP level of more than 150 milligrams per liter. And again, urgent ERCP was defined as an ERCP that was performed within the first 24 hours from hospital presentation. And the primary endpoint of this study was a composite of mortality and other major complications within the first 6 months from disease onset. The primary endpoint occurred in 38% of those that underwent urgent ERCP versus 44% in those with conservative treatment. And this difference was similar statistically. As it was mortality, the only significant impact that the urgent ERCP had is in reducing the risk of cholangitis, which was from 10% to 2%. Again, this is a very selective group. These are predicted severe gallstone pancreatitis patients where urgent ERCP does not seem to have a role. But overall, early ERCP is indicated in gallstone acute pancreatitis and concomitant cholangitis. How can we say that someone has cholangitis, though? This is defined as fever plus either presence of CBD stones on imaging or a dilated CBD or progressive cholestasis, meaning progressively worsening LFTs of a cholestatic pattern. And again, as we said, based on the Dutch Pancreatitis Group, urgent ERCP is not indicated. Moving along to the third topic of the discussion, antibiotics. We're first going to focus on extrapancreatic infections. I want you to remember that extrapancreatic infections that can be bloodstream, pneumonias, or urinary tract infections, these are the three most common sites, occur in approximately 20% of patients with acute pancreatitis. And studies have shown that extrapancreatic infections are associated with increased mortality. So when we have a suspicion for infection, we should initiate IV antibiotics while we are investigating the infection source. However, if the blood cultures or other cultures are negative and no source is identified, the antibiotics ideally should be discontinued. Prophylactic antibiotics or selective decontamination of the intestines are not recommended in acute pancreatitis. Moving to pancreatic necrosis. Now remember, approximately 10 to 20% of all comers with acute pancreatitis, especially at tertiary medical centers, will develop pancreatic necrosis. You can see here in the 3 CT cuts how a normal pancreas looks, where the whole pancreatic parenchyma is enhancing, and you can also see some radiopeg stones in the gallbladder and a large cyst in the left kidney. And then a few days down the road, there is non-enhancement pancreas consistent with necrosis. You can see the difference of the bright enhancing tissue on the first imaging with the hypodense non-enhancing tissue in the middle. You can also see a Dopkov tube here in the duodenum. And then further down the road, the necrotic collection becomes organized with the development of a capsule, as you can see. From those that develop pancreatic necrosis, approximately 20 to 30% will develop infection within the necroma. Infected pancreatic necrosis more often is seen later in the clinical course, usually after the first 10 days of presentation. Around 75% of infected pancreatic necrosis is monomicrobial, with gut-derived organisms such as E. coli, Pseudomonas, Klebsiella, and Enterococcus. However, the incidence of gram-positive, multi-drug resistant, and fungal organisms is rising within infected necroma, so we have to keep that in mind. When do we suspect infected necrosis? Usually what we see clinically is a clinical deterioration or no improvement after the first 7 to 10 days of hospitalization. How do we define clinical deterioration? The patients might start developing unstable vital signs. They might become hypotensive or tachycardic. The WBCs are usually increasing. The patient may develop fevers, worsening abdominal pain, and not all the time, but on occasions we will see presence of gas within the pancreatic necroma. Presence of gas is pathognomonic. However, there are a lot of infected necrosis without gas on CT scan. If this is the case and we have a high clinical suspicion, we should initiate empiric antibiotics intravenously, and we have to select antibiotics that we know that they penetrate the pancreatic parenchyma. We can use either carbapenems alone, or we can use a combination of quinolones, ceftazidime, or cefepime with an anaerobic agent such as metronidazole. Now, if we initiate the antibiotics, but the patients continue to be unstable after 48 to 72 hours, that's when the time that we need to drain the necrotic and decompress the necrotic collection. And at the Ohio State, the preferable route in those unstable patients that usually are in the ICU for draining the necrotic collection is via interventional radiology. Over the last 10 years or even more, the role of CT-guided fine needle aspiration to confirm infection is really limited in pancreatic necrosis. We don't do that anymore. Now, if there is infected pancreatic necrosis, however, the patients are stable on antibiotics, then we don't need to intervene urgently, but we can delay the drainage or debridement by continuing the antibiotics for ideally 4 weeks when at that time we can perform endoscopic decompression and debridement. This is the preferable route that we use at the Ohio State University. Just a reminder as I wrap up, I will start with the other slide first. These are some landmark studies by the Pancreatitis Study Working Group, starting with Panther back in 2010. It's almost 15 years old, where in a randomized control fashion, we found out that the step-up approach is preferred to open necrosectomy for necrotizing pancreatitis. This was followed by the Penguin trial in 2012, and then eventually the Tension trial in 2017, where we found out that a step-up approach that can be done either endoscopically or surgically is the preferred way for infected necrotizing pancreatitis, with a small asterisk that likely endoscopic approach might result in less pancreatitis fistulae. And finally, more recently, we had the Pointer in 2021, which focused on the timing for the treatment of pancreatic necrosis and compared immediate versus postponed intervention for infected necrotizing pancreatitis. And by immediate drainage, we mean drainage within the 24 hours once infected necrosis has been diagnosed. And what we found in the postponed drainage group, which actually does as well as the immediate drainage group, approximately 40% are doing well just with conservative treatment antibiotics and did not require any drainage at all. I will conclude here and thank you for your attention.
Thank you very much, George. Tessa is going to introduce our next speaker if he's here. Tessa?
I don't think that I see him logged on yet.
Okay, then I think we might.
Can you make sure, it's Steve Hughes here. Can you send him an email with his logon information? Just make sure, and then I'm gonna leave the call and I'll call him. He should be on very momentarily. So I'm gonna log off, call him, and then I'll log back on.
Okay.
Okay.
Yeah, in the interim, we can just take questions and perhaps discuss this part of the talk while we wait. So if anyone...
I had a question to start off. So Dr. Papachristou, what do you do if we miss that 24 to 48 hour window to initiate the fluids, that the patient tried to, started with symptoms and tried to wait it out at home, or went to an outside hospital and then is being transferred in and they didn't start fluids at that time? If they're more than 48 hours after the onset of symptoms, what do you recommend in terms of the fluid resuscitation? Say if for instance that in a more simple case or a more mild case that their laboratory values, their vital signs, everything is nice and stable with no concerns for hemoconcentration, would you give them fluids, or would you just sort of do the other things with advancing their diet and pain control and things like that?
Yeah, usually in the predicted mild, it's a good idea within the first 24 hours or when the first 24 hours are completed to initiate oral diet, oral nutrition. At that point, we can maintain just some fluids at around 100 cc's per hour, depending on the size of the patient. And when they are able to tolerate oral intake, I think that might be time to even discontinue fluids and start preparing them for discharge as well. Now, if they are severe or if they're not doing well and we are out of the 48-hour window, aggressive fluid resuscitation, I have a feeling that it won't reverse things. If they are going more into an systemic inflammatory state, the more fluid we give, the more extravasation in the third space we'll have. So again, clearly the early first 12, 24 hours are critical for what I call adequate resuscitation. So we have to be early and adequate and not aggressive.
Wonderful. Thank you so much. There's a couple other questions in the chat, but Dr. Rosenthal has joined, so I think it's best if we go ahead and allow him to do his presentation and then sort of wrap back up with all of the questions. So I do see the two in the chat, and we'll get back to those after Dr. Rosenthal. So welcome, Dr. Martin Rosenthal. He is an associate professor of surgery at the University of Florida, Division of Acute Care Surgery. He is also the director of the Abdominal Wall Reconstruction and Intestinal Rehab Service and chair of the University of Florida Nutrition Committee. So Dr. Rosenthal, thank you so much for joining and looking forward to talking about diet and nutrition.
Fantastic. Thank you so much for having me. And I apologize for being a little bit tardy. I just got out of the OR and raced home in the rain. Luckily, as a trauma surgeon, I didn't have to run too many red lights. So here we are. Let's see here. I'm going to try and share my screen. Let's see. There we go. Put it in presentation mode. How's that? Everybody see my screen?
Yeah, it looks great.
Awesome. All right. So Dr. Hughes had asked me to kind of present, we shared some thoughts at a recent NIDDK kind of format when we got together, and this talk kind of hashed out a little bit of nutrition for pancreatitis and what we have been doing, kind of maybe a little bit newer approaches and some exciting new research that is being developed as we talk. And I'd like to disclose that I basically have no disclosures other than various nutrition companies. The learning objectives for this one is kind of straightforward. What we know, so recommendations of enteral feeding in acute pancreatitis. New approaches is going to be focused more on anti-inflammation, anabolic nutrition, and then kind of research. And spoiler alert, but I do think that specialized pro-resolving mediators are going to be the future for certainly helping our very inflamed patients hopefully decrease the inflammatory nature of this disease process and deliver a little bit better nutrition that is targeted for these inflamed folks. Because ultimately, I think when we decrease the inflammatory process, we can certainly help decrease the amount of catabolism and preserve lean muscle mass, which also clinically equates to having folks less weak, a little bit more robust. So not necessarily knowledge gaps, but in the United States, acute pancreatitis, leading cause of inpatient GI disease, 275,000 are hospitalized per year, equates to about 2.6 billion. Acute pancreatitis ranges from 5 to 30 cases, and enteral nutrition versus parenteral nutrition always seems to be at the root for what kind of nutrition we should deliver when we should go to parenteral nutrition. I do think that the literature basically supports enteral nutrition when we can, but there are certain cases where that's not going to be tolerated, and when we go to parenteral support, what it should look like. And then dose-dependent, multi-organ dysfunction. The more inflamed the patient is, the more the pancreas is being consumed by the inflammatory process, I think ultimately equates to how patients become chronic critically ill. And I say plus or minus PICS. A lot of my mentorship with Fred Moore was with persistent inflammation, immunosuppressed catabolic syndrome, not to be confused with the post-intensive care syndrome, which basically looked more at folks that had delirium, PTSD and stuff from being in the ICU. But the persistent inflammatory immunosuppressed catabolic syndrome is what happens when we have dysfunctional multi-organ system involvement and what that might look like. And so when we have a person with really inflamed pancreas, you add a little advanced age, and those folks do progress to the PICS phenomenon. This slide basically is going to go through various recommendations found in the Aspen SCCM guidelines, and I also have a few other recommendations from various bodies and societies. But as you can see here, you know, when you look at the force plot of various studies, it basically favors post-caloric enteral nutrition, obviously, over parenteral nutrition. You have a decrease in infectious morbidity. You actually have a decrease in mortality. It's very difficult oftentimes in our nutrition literature to see a benefit in mortality, because it's very difficult to get any study through the IRB process when you randomize folks to some nutrition over a different nutrition. Some nutrition to no nutrition is not going to ever be allowed. And, you know, the IRB is very stringent, and they're going to ask, why are you going to do EN versus PN? And so when you look at nutritional support, it's very difficult, because those studies really need to have tens of thousands of patients enrolled. And so you can see with the force plot that there is actually a mortality benefit associated with enteral nutrition. Here you can see the ESPEN, or the European guidelines. So EN is preferred. You have a decrease in mortality, again, multi-organ failure. With YAO, you have a decrease in mortality, hospital length of stay, and certainly risk of complications. In acute pancreatitis, enteral nutrition is recommended to prevent infectious complication. And certainly we see that continuing in various formats throughout the recommendations. So why is enteral nutrition important? I can't stress this enough. Certainly with the advances that we're starting to see with the microbiome and supporting the microbiome, and not only health, but also in illness, is a growing body of literature. And when you look at the microbiome and you look at the crosstalk that happens with the host and the patient, you have better immune function with energy that is delivered to the gastrointestinal tract. With severe acute pancreatitis, you have a decrease in the septic syndrome, and you actually have you have an increase in gut barrier dysfunction. And so when you give the enteral nutrition into the lumen, you preserve the tight junctions, you preserve the integrity of the lumen, the microvilli, you support the microbiome, you enhance immunity. And as you can see from the bullet points, you know, it attenuates the stress response. You have decrease in CRP and glucose intolerance. You actually have a decrease in IL-6, which are all just biomarkers for inflammation. And enteral nutrition, you have faster resolution of organ dysfunction and disease process. Continuing on, what about the timing of nutrition? You know, early versus delayed. This is also true for just sepsis in general. It's basically known now that the earlier we can get enteral nutrition in, you're going to have better clinical outcomes, less pancreatic infection, multi-organ failure, ICU, and you can see those that they are all statistically significant. But the interesting thing that I would raise to the group would be, you know, when we provide early enteral nutrition to these folks that are severely inflamed and have organ dysfunction, it's probably not the caloric benefit that we are giving them. It's the non-caloric benefits of what we just talked about on this slide, where they're preserving their tight junctions and they're having less multi-organ dysfunction. They have better benefit from the non-caloric delivery than they do actually from the caloric benefits. We could talk about that, but you know, there's Yvette Luking. There's also Greet Vandenberg has looked at autophagy lately, and so I do think that there are different bodies of literature that support that early delivery is going to be better, and it's going to be more for the non-caloric benefits again. Baker, which we'll touch on in a second, had a meta-analysis. Enteral Nutrition had randomized controlled trials. You can see that there was about 165 patients. The composite outcomes, there was a decrease in mortality, organ dysfunction, and organ failure, infection, necrosis. And you can see that, again, multi-organ failure was decreased as its own outlier. Petrov, another meta-analysis, 11 randomized control trials. Again, the signal is there, decreased multi-organ failure, infection, mortality. And so early delivery, I do think, is important. And we're going to do it with the enteral route and not the parenteral route. Now, this one I found was interesting when we were looking at some of the literature. The notion of pancreatic rest and getting post-caloric tube feeds going via DOP-off or whatever mechanism you want. One of the things that I felt like I kind of grew up with, because of this notion that you're going to get it past the pancreas and you're not going to stimulate it with your nutrients, may actually indeed be a little bit of a fallacy. There was actually 3 randomized control trials looking at this, and they all had no statistical difference between NG versus NJ, and that they were all tolerated equally, and that they were all able to deliver adequate calories to these patients. To me, that seems a little bit aggressive. There's the sentinel loop. You may have duodenal dysmotility, and delivering nutrients into the stomach. You may just set up for potential aspiration, because I don't know how much is going to be emptying into the duodenum. But I open this up certainly for discussion. I'm just here to show you the data that we found. And, the NJ still makes sense, I think, in multi-organ dysfunction when you have an intubated patient. But it can be a little bit anecdotal at this point. With chronic pancreatitis and folks that continue to have ongoing years worth of pancreatitis, the gland is basically burnt out. They have severe pain. I do think when you talk to these patients, they all claim that they have less pain and they have less inflammatory biomarkers when you actually do a NJ or a J-place tube. So there might be a role in chronic pancreatitis as opposed to acute. So how to feed, again, looking at this, L3B looked at a recommendation where they suggested that enteral nutrition to be provided to the patients with severe pancreatitis. There is no difference in tolerance or clinical outcomes between these two. And you can see that there's also a meta-analysis of about 157 patients. So here's Olaf Baker. He was with the Dutch pancreatitis group. He published this randomized control trial looking at feeding the stomach versus post-pyloric, giving a PO challenge after 72 hours versus enteral nutrition. It was the Python study, if you want to look it up. You can see that the groups were very similar. The take-home message from this was that in the oral diet group, 69% of the patients tolerated an oral diet and did not require tube feeding at all. And so I think what this is kind of shaking up at this point is that if you have a patient with pancreatitis, if they're hungry, feed them after about 72 hours of a little bit of rest. There is no kind of clinical difference between those groups. It seemed like it was pretty well tolerated to the tune of about 70%. Some of them did ultimately end up having nausea. Some did have emesis. But 70% of these folks could just get away with a PO diet as opposed to subjecting them to NG, NJ tubes and delivering nutrients via the tube feed route. And so I think that's kind of important to touch on. So what to feed, we suggest using a standard polymeric formula. Although there is promising data that is coming out, there is still limited to no recommendations on using immune enhancing formulas or immunonutrition. And I do think that that is probably where the wave of the future is going to show that there is positive impact, and we can touch on that. Looking at Braunschweig's study, this is an ESPEN guideline, and G1, Aspen and SCCM. We suggest that in patients at low nutritional risk, meaning we've done an NRS 2002 or a Nutrix score. For those unfamiliar with those are inpatient scores that we can assess the malnutrition risk of a patient. So below 3 for either study is not at risk. And then above 3 is at risk. Nutrix score, anything above 5 is at severe risk of malnutrition. And you can get points for age, inflammation, disease process. And so ultimately, it kind of is a marker of not only just risk for malnutrition, of frailty and disease process combined. They basically are recommending that PN be withheld for 7 days unless the score is high. And if it's really, really high, then you can start it at about day 4. But we still follow Michael Kaiser's study out of the UK when he compared the Aspen versus ESPEN guidelines for starting parenteral support. Basically, you accrue a lot of the septic morbidity that comes with central line and pouring parenteral support into a main vein. You don't get much benefit if you are nourished coming in. And so ultimately, in the United States, the guidelines remain that we should probably be waiting for about 7 days before we feed a nourished patient. But if they're elder, frail, and you have a good clinical indication that they're not going to tolerate their oral or enteral support, then it's okay to go to parenteral after day 4. So new approaches, anti-inflammatory and anabolic. I participated in a meta-analysis looking at omega-3 fatty acids. This was a parenteral omega-3 fatty acid study, but the signal is still true with oral support. So omega-3 fatty acids basically are fish oil. There are companies now developing alga formats, and some of the alga formats seem to be a little bit more sustainable than harvesting fish. And it's cheaper. The alga farms actually produce a lot of oxygen. It's more environmentally friendly, but you can see that the omega-3 fatty acids, you have a decrease in infection, so 40% lower, decrease in sepsis. Length of stay was decreased by about 2 days in both ICU and hospital. Again, there was no statistical significance in reduction in 30-day mortality, although there was a strong signal. And so I do think that omega-3 fatty acids certainly would be beneficial for pancreatitis, both acute and chronic. Looking at anabolic nutrients, specifically amino acids. So arginine is a conditional amino acid. There's a deficiency during severe stress. So you can see the ones listed, those aren't certainly all inclusive. Certainly in the PICS model, you can actually have an uptick in myeloid-derived suppressor cells. These myeloid-derived suppressor cells actually consume arginine at an inordinate rate because they secrete arginase, and arginase just turns arginine and breaks down the elemental forms of the amino acid. And so you get arginine depletion in persistent inflamed immunosuppressed catabolic syndrome. We saw that with Phil Efron's study. It was actually pretty elaborate. And so when you have pancreatitis, you have a conditional amino acid getting depleted. You're asking, well, why is that important? Well, the T cell function is actually one of the more important issues, because the zeta chain on the T cell receptor requires arginine to be functional. And if your zeta chain isn't functional, the T cell receptor is not functional. And if your T cell receptor is not functional, that T cell is rendered basically non-functional, and your innate and adaptive immune response actually takes a pretty big hit. Now, it's not global. We still have immune function, but the arginine is required for that zeta chain. And during pancreatitis, I do believe that this would be beneficial. Now, there is a controversy over giving patients with SIRS and sepsis arginine because there's nitric oxide synthetase, which requires arginine to turn into nitric oxide. So there are some folks out there that believe that arginine with inducible nitric oxide would get shunted into a production of widespread global systemic nitric oxide. That has actually been never proven, and it's been disproved. Yvette Luking in Texas did a very nice study looking at severe sepsis on pressors, and there was no change in mean arterial pressure, pressures, systemic pressures, and even carbon dioxide production in the gastric mucosa sensed by a balloon adaptation where she dropped an NG tube with a balloon. She was looking for carbon dioxide and lactic acid, and what ended up coming across the membrane consumed by the balloon, she can actually study that fluid, and there was no increase in that. So there was no mucosal signs of ongoing malperfusion with severe sepsis. Also, arginine is required for wound healing. And if we're going to ever do any kind of interventional surgically for our pancreatitis patients, it'd be nice to have some good collagen matrix to heal. And then it's anabolic with leucine in the mTOR pathway. And as you can see, leucine here stimulates the mammalian target of rapamycin. It's the master regulator of cellular organ and organismal growth. There's two distinct forms. mTOR1 is cell growth, but mTOR2 promotes cell proliferation and survival. And so what you end up having is this is a pathway for anabolic nutrients. And if you exercise at all, you take protein powder or you take protein shakes, you're actually looking for the branched chain amino acids such as leucine and arginine to stimulate the anabolic growth that you can have. And as you can see, it's synergistic. And so I'm going to very rapidly go through this so I don't run out of time, but here's the specialized pro-resolving mediators. There's different pathways, but there's E and D, there's merisins, protectins, neuroprotectins has been shortened back down to protectins. And what you can ultimately see is that these SPMs, the specialized pro-resolving molecules, are pluripotent lipid-derived, bioactive components of omega-3 fatty acids. And you don't need a lot. It's nano and picomolar. And you can see that through all these different animal studies, there could actually be a role for pancreatitis going forward. So I'm happy to discuss anything else, but in summary, there's robust evidence with pancreatitis. We obviously go with EN over PN if we can. Level of delivery doesn't really impact the disease as we once thought. Polymeric over elemental, unless you're having signs of potential dehydration with exocrine pancreatic dysfunction, the elemental formats may actually help a little bit there. And then there's growing support for immunonutrition, and I do think specialized pro-resolving mediators are the future. Again, I apologize for being late. I'm sorry if I went over time, but I appreciate everybody's attention. Happy to answer any questions.
Thank you so much. That was awesome. I suppose let's pull up the chat. So going back to Dr. Papakristo, we'll hit these two questions and let people kind of stew on the nutrition and diet part of things. So Dr. Papakristo, directed towards you, what do you think will be the future prospective studies in the field of acute pancreatitis? That's a loaded question.
Future prospective studies, as far as clinical trials, first of all, we're waiting for some exciting result from a study that was recently completed, the carpot trial, which tested the calcium channel inhibitor, and it appears to have promising results. But in my mind, acute pancreatitis is a syndrome that involves different pathways. as far as pathophysiology of the disease. So in many ways, we're gonna move forward similarly to other acute inflammatory disorders where we may need a combination of agents, or some agents might work for one path and others for other paths. Definitely immune modulating treatments are out there too. Interleukin inhibitors, TNF-alpha inhibitors. There's a big study, the RAPID trial, that is ongoing now in Europe with Remicade. So a lot of exciting stuff coming up.
Wonderful, thank you. And then Mitch had asked the other question. You mentioned in your practice for sick patients with infected necrosis is for IR to usually drain those. What happens if you do endoscopic cystgastrostomy in those sick patients?
The challenge with those patients is that they are early in their disease process, so the necrotic collection is still very mature, and there's not a very well formed, or it's a partially formed wall. If we do that endoscopically, we're risking of popping up the opposite wall or having air into the peritoneum, whereas in this case, it's an IR drain. It's a much more straightforward, in my eyes, procedure, and you're mainly looking for decompressing, taking out some of the fluid, decompressing the collection, and help the patient to come over the clinical instability that they are. It can happen. There are some studies with very early endoscopic approach, with especially with the lumen-opposing metal stent that we can place now, US guided. But again, I tend to be more conservative. I would prefer IR route with a percutaneous drainage in the early and stable patients. And down the road, you can also do a two-axis process where you have the drain and then you place also a lumen-opposing metal stent, and then you can be more aggressive with flushing through the drain.
George, a follow-up question. Thanks for your presentation. Now, in this early phase of necrotizing pancreatitis, where it can be difficult to differentiate whether it's SIRS that's driving it or infection, for our colleagues in the community setting, where surgeons like Dr. Hughes may not be available, what is the threshold at which you would pull the trigger for recommending IR drainage in this early phase? And would you even recommend it at all in the community hospital setting? Or would you make these decisions only at a tertiary care center?
First of all, I will start with antibiotics if I have a high clinical suspicion, and I will give hopefully 24 to 48 hours in the antibiotics to see if the patients will improve with that. And as the studies have shown, 40% of these patients won't even need any sort of drainage, correct? But if there is no improvement with 24, 48 hours on antibiotics, on a good regimen with good penetration into the pancreatic parenchyma, I think that will be the time for drainage. And it's all up to the expertise of the center. Granted, my advice would be have a lower threshold to transfer to tertiary referral centers, but I might be a bit biased as well, working on a tertiary referral center. So it all has to do with the expertise, I would say.
Fuck, go away.
Sorry?
I think Dr. Hughes is unmuted. I think, yeah, it is sometimes difficult because, you put a drain in and it's not always 100% clear whether it's a sterile collection or not. And then if it, a percutaneous drain leads to an early, truly infected necrosis, and you're in a center where there is no pancreatic surgical expertise, I do feel like it can be a tricky situation. So, but I think the point about trying antibiotics first, I think, is an important one. Thank you.
If you don't mind, it's Steve Hughes here. I hope everyone can hear me. I've had trouble with connections. I think it's really important to note that 25% of patients with severe pancreatitis, including necrosis, will resolve their disease without any intervention. But if you put a drain in those patients, you have now taken a sterile collection and colonized it. And those folks will have to convert over to something. And so we like to scan people once a week and watch their clinical course closely. I think George talked about this clinical decline. I think it's it sounds hard in concept, but in reality, you see it. The first 2 weeks are SIRS. They get sick, they get better, and then they get sick again. And when they get sick again, it's infection. If they don't get sick again, they might get by without doing anything. And more importantly, infection is really rare in the pancreas in the first 2 weeks. Like Dr. Papacristo mentioned, it's more likely the lungs or the bladder or maybe the central line you put in. So in those first 2 weeks, you should kind of assume it's most likely SIRS and not infected pancreatic necrosis. And if they don't get better, if they start to get sicker, then that's when you intervene. And then while I've got you on the phone, Martin, you didn't talk about, there's a trial that shows that early initiation of parenteral nutrition actually is associated with higher mortality. So you don't need to rush to nutrition unless somebody is truly frail and nutritionally depleted. In fact, you might cause them harm. You've got 4 or 5 days to just let them kind of settle out. And I'll be happy to take any questions.
I 100% agree with you, Steve. Like when you're super inflamed and the SIRS response is burning in the early phase of energy deliverance, even the liver undergoes hepatic reprioritization. You see a drop in albumin, you see spike in CRP. In the throes of everything, that is not when the nutrients are going to be 100% utilized and digested and providing what we would consider the calories for protein building, gluconeogenesis, and most of that's going to come from catabolism. And shutting that mechanism off in our pancreatitis patients and stopping seeing those folks, like you said, when they hit that second spike and get that infection, some of these people get so weak and so frail, and it's not from lack of nutrient delivery or supplements or whatever. It's just they just sit there and their inflammatory cascade is so revved up that they just sit there consuming their lean muscle mass. And those are the folks that are not good from door, as we used to say. And those are the folks that don't do well with a major operation if we have to do any kind of intervention on them.
I think we have a couple other questions on the chat. What is the best tool to predict severity in your clinical practice? George, would you like to comment?
Sure. Unfortunately, we don't have a great tool, as you all know, or you may know. I tend to use a simple clinical score, and I also tend to rely a lot on the risk factors that a patient has. So remember, obesity, especially in males, alcoholic etiology. There are clearly risk factors that you have to consider while you're assessing the patient. I tend to use SEERS as my go-to clinical score just because it's very straightforward. It's only 4 criteria. 3 of them are vital signs, temperature, heart rate, and respiratory rate. And the 4th is the WBC count, which almost everyone has it at the time of the assessment. And also remember, it's a dynamic process. So repeat your assessment in 6 hours. See if the patients are doing better, if their vitals are improving, if their BUN is not increasing or dropping. And again, we are hopeful that in the future we'll have better tests. Peter and I are working on a multi-cytokine panel. We're in the validation phase now, and the next step will be to develop a point of care test from that. So hopefully down the road, we will have better tools, not just for prediction, but also for guiding the design of the future randomized controlled trials as well.
Great. And then one other question in the chat directed towards Dr. Rosenthal. If you had to put a hospital day number on when to commit to a nasal gastric or nasal jejunal tube, what would you choose? 3, 5, 7, or does it just depend on the baseline nutrition status?
I'm assuming that is an NG tube for feeding, but honestly, I would do it still day 1, but there's this idea and a difference between trophic feeds and doing trickle feeds. So it kind of depends on what your intent is. Trickle feeds is just to deliver a little bit of intraluminal nutrition. Typically it's 10 cc's and just trying to see if the patient's going to tolerate anything. Trophic feeds is a little bit different intent. It can still be the exact same volume, but it's all about intention. So trophic feeds is still going to be giving some intraluminal nutrition so that you can keep everything happy again. And so the non-caloric benefits of that have been shown time and time again. But I'd still do that. Now, if you're talking about when would you commit to going up to goal, I agree with the comment made earlier. Certainly by the end of the week, we should be getting to some semblance of goal caloric delivery. But I would always be watching out for enteral nutrient intolerance of whatever we're delivering. These patients do get ileuses, and so I certainly am watching for that. But I don't think checking gastric residual volumes and stuff like that. I think that's kind of old, antiquated literature that we don't support anymore. It's more going off of symptoms and what the patient is telling you.
And in your practice, just a follow-up to that, do you encourage early use of pancreatic enzyme replacement therapy? Oftentimes in my practice, I'll have them hook a Relazorb cartridge, in line with their enteral feeds, just especially in my really sick patients, just to sort of, I don't know if it just makes me feel better or just to help with their absorption of the feeds that they're receiving. Is that something that you use?
We do that. We were actually one of the first institutions that adopted Relazorb as a kind of almost like a pilot. We actually even adopted it into what they are calling the ICU diarrhea protocol. Now, I think that was a little bit of a bastardization of the product, but the bedside nurses like it. I do think it decreases some of the diarrhea related with exocrine pancreatic insufficiency. There was a study out of China, although arguably, not the best literature, but there was, I think they showed 60% of really critically ill folks have some pancreatic exocrine dysfunction. So we actually do use the cartridge. I also, I like to be a little bit more data driven. So we do check stool enzymes, and we try and make sure that we're not just giving something. And I mean, those cartridges aren't exactly cheap, but I think they're like $50, $75 a cartridge, if I remember correctly. So they're probably not the most expensive thing that we do to folks in the ICU. But we go data driven, but we do like the reliable cartridge for sure. And the other thing I would throw out there is they're actually cheaper to use the cartridge with polymeric formulas than it is to actually go for elemental tube feeds on a daily.
All right, thank you so much for the answers. And we are over time, so I'm going to go ahead and wrap up. Thanks to all of our speakers, moderators for joining us for this first session. And when I say first, I am hinting that there's a second, third, and fourth coming throughout the month of September. So same time, same place. Next week, the topic is going to be, I had it and I lost it. It's about etiology of acute pancreatitis. We'll have a session on genetic testing in acute pancreatitis, and then a session on diagnostic endoscopic ultrasound in idiopathic pancreatitis. So look forward to seeing you all next week. Thanks again for your time, and we will see you around.
Thank you.